Tonight's forum is about bringing healthcare home. What does that mean for Santa Barbara? And more importantly, what does that mean to you? Our healthcare industry is constantly evolving. Navigating the system is complicated for both providers and patients. In the coming months and years, there are significant changes stemming from national regulations and legislation that will change the way that healthcare is organized, accessed, and paid for. To help us answer how this will impact Santa Barbara's healthcare community, it is my great pleasure to introduce our keynote speaker, Tracey Moorhead, President and CEO of the Visiting Nurses Association of America, and someone that I'm very proud to call a friend. Tracey, come on up. Tracey spearheads the strategic vision and growth for her national organization, which represents nonprofit home health, hospice, and health promotion communities. She is recognized as a leading healthcare advocate with considerable experience in public policy and coalition development and outreach. She previously served as President and CEO of the Care Continuum Alliance, Executive Director of the Alliance to Improve Medicare, and Vice President of Government Relations for the Healthcare Leadership Council. Welcome, Tracey.
Thank you so much. Thank you. Thank you all so much. First of all, thank you for coming indoors on such a lovely day. You all know that you live in paradise, and so I would like to ask you to please stop apologizing to me for the weather every time I come here. I have been here for a couple of days, and it did rain yesterday, but it was fine because it was still lovely. I saw a double rainbow, and it was a gorgeous day. And when I was here in September to help the VNA board with some strategic planning work, you were having a heat wave. It was 80. And everyone kept apologizing to me everywhere I went. Meanwhile, I live in Washington, D.C. It was 100. So I was quite happy to be here with 80 degrees, and I'm happy to come back anytime the VNA will have me. I do want to recognize the VNA's leadership, Lynda and Rick, for putting this event together. Thank you so much for inviting me. And I want to congratulate CenCal for the award. Bob, I thought what you just did with your staff was incredibly impressive and generous on your part, and I think that's a testament to the leadership that you have shown with the plan to generate the recognition that you received this evening. It is true that most folks don't understand what a health plan does. And what you did here this evening by calling out the work that Cody and Lauren and Ariana and their other colleagues do is really critical to the success of any health plan. So congratulations to you for your leadership as well. Thank you. So I'm going to spend some time this evening talking at the big picture level about some of the trends that are impacting healthcare delivery across the country in communities like Santa Barbara. I do want to preface this, okay, don't go there. I do want to preface this by saying that Santa Barbara is very unique. You do have something of a unique microcosm here, not only in terms of the beauty of your community, but the small and integrated components of your healthcare delivery system. It's very interesting to learn more about the healthcare delivery and the partnerships that happen here in Santa Barbara, but it's not replicable in other communities across the country. Other communities might have 15 to 20 different payers or health plans, or 15 to 20 different physician group practices or accountable care organizations. And it's very, very difficult to bring all of them together in the types of partnerships that have been so successfully forged here in Santa Barbara. So I do want you to keep that in mind, but I am going to talk about some of the trends that we see across the country. So as I was sketching this out for you a couple of weeks ago, I just started to jot down some of the things that I think are most commonly and impactfully driving healthcare reform across the country. And I know that Rick mentioned that this is the third year of this event, and for the first 2 years, the presentation is really focused on the implementation of the Affordable Care Act and what that means for communities across the country. We've kind of moved past implementation of the Affordable Care Act. It's not going anywhere. It doesn't matter who's going to be elected president, Democrat or Republican, or a third party, or even Bernie Sanders. Whoever it is going to have to deal with the implementation that's already taken place of the Affordable Care Act. And you see that here in your own community with the cottage physician group and some of the other quality initiatives that CenCal and others have begun to implement. So these are some of the trends that I'm going to dive in on this evening, and I think as we go through them, a lot of what Bob said about the various divisions of the plan and the work that you see at the VNA, Visiting Nurse and Hospice Care will resonate with you. So the first one is population health management. And you're going to hear from one of the representatives from Cottage later on the panel, who is an expert in population health management. I've been working in population health management for almost 15 years now. And when we first started, nobody knew what it meant. It was kind of a unicorn. What is it? How do you know it when you see it? How do you do it? How do you prove that it actually works? Well, now population health management is about the hottest thing going in healthcare delivery. Everybody wants to talk about their population health management plan. And it's really critical because it really drives some of the other trends that we're going to talk about in the other trends that I have here in the presentation. But it really does represent a longitudinal and integrated approach to care. It's not just serving someone once they've been diagnosed, it's helping someone with a risk factor for a chronic condition as well. And increasingly, as we see population health management maturing and evolving, we're seeing a lot of different factors of the healthcare delivery system coming together that we hadn't seen being integrated before. Many of you in the workforce probably understand that mental and behavioral health programs offered by your employers are completely separate from your regular healthcare, the clinical part of your healthcare delivery programs. Increasingly, particularly for state-based populations, Medicaid populations particularly, we're seeing an integration of the behavioral, the mental, the clinical, in a recognition that these are important components to really drive success in keeping people healthy and out of the hospital, keeping them from going back to the hospital. And so those social determinants of health, some of the behavioral health issues, some of the mental health issues, some of the other risk factors that we have in our various communities are becoming much more important components that are driving the evolution of population health management. Some of the key components, and I just want to level set here, of population, and this is going to flow through some of the other trends that I talk about later. How do you know population health management when you see it? You know it by the core components, and if you're missing any one of these components at its most basic level, you're not effectively implementing a population health management program. The first thing is the identification of your population. Who are you serving? Is it a dual eligible population of Medicare and Medicaid, or is it a low-income population that may need LTSS services? Then there's the assessment of your population. Where do they fall along the healthcare continuum? There's the risk stratification of your population. What is it that they need, and what are their risk factors for the development or the mitigation of a chronic condition? The engagement and intervention of those individuals in the various segments of those populations, then the measurement of the outcomes. And then most importantly, there's the repeat, because people are always going to be moving throughout that population health management spectrum. This is somewhat of a visual of that, and this is really important as we look at the integration of the various segments of our healthcare delivery system. I typically now work with the post-acute care section of the healthcare delivery system, and that's really the home health and the hospice and palliative care segment, really represented on your right side of the slide here. But increasingly, we see opportunities to engage those populations that are well and healthy, or who may have minimal risk factors, so that we can keep them from becoming post-acute care populations. This also represents considerable expansion opportunities for many providers across the healthcare continuum. Where can they go with their services? Where can they take their expertise and really begin to provide a greater continuity of services across this care continuum? One example is in the home health community that I work with now. We see a gap really between the post-acute care services that home health typically provides and the end-of-life hospice service that we have also traditionally provided. That gap is really an opportunity for us to begin to infill advanced illness care and even palliative care for those individuals who are not yet ready for end-of-life hospice services, but who may benefit from palliation of their conditions. The second trend is really data, and we heard Bob Freeman talk about the critical role of data in their decision to pay claims and how much a provider is paid for their services. In fact, we've seen this evolution from data just being collected to pay those claims to data being collected for much more sophisticated applications. And typically these have to do with identifying those populations, stratifying those populations, and really understanding what patients are going to need and anticipating the needs of populations, even down to the individual patient level. Data is king. If you do not have data, whether you are a VNA or a hospice, or you are a provider group, or you are any type of healthcare provider in the community, you must have that data to understand the population that you are serving, to understand their needs, to understand how you are performing as a provider in that community, and more importantly, how you can improve. We're going to talk a bit about why that's important in just a minute, but this critical role of a more dynamic and predictive analytic application of data is really foundational for success in the new healthcare value economy that we see emerging across the country. This is just a representation of the use of data across a population health management model. And so we've got the definition of the population, the identification of the population, the stratification of the population in terms of how chronically ill or at risk they are, the engagement, the management, and the measurement. In the middle are the types of applications that you utilize for the successful utilization of data to manage these populations and execute a population health management program. These are just some examples of the different levels of data that we need, starting with the individual level data. This has to do with what is a patient's clinical or functional status. Are they ambulatory? Can they get up and walk around their house? Can they remember to take their medications during the day? Do they have a caregiver at home? These are very important components, understanding how a patient can best self-care and who they have to support them at home to successfully manage that care plan. In the middle, you have a population level data analytic requirement. And this is really to help manage specific populations, such as the dual eligible, those Medicare, but also Medicaid eligible populations. And then on the end, we have the enterprise level. And this is what you would really need at a health system level, a system that includes a hospital, a provider group, and perhaps even a health plan, as we increasingly see all of these factors of healthcare delivery coming together. And this is where it's very important to understand cost. The cost of care delivery is very important for the enterprise level to understand, so that you can ensure you're providing the highest level quality service at the patient level at the lowest possible cost. We're going to talk a bit about how to ensure that in just a minute. What's driving this, or how is this data driving healthcare delivery reform in the communities? And it's really resulting in rapid consolidation across all industry segments. So whether it's the payer community, which is the health plans, or the provider community, whether it's physician groups or even hospices or home health providers, we are seeing across this country an unprecedented amount of consolidation or M&A activity, merger and acquisition activity in some of these areas. And it's really because of the need to scale up and expand a scope of services. Bigger is going to be better. The more services you can offer, the more consolidated across the care continuum you can become, the lower you can keep your cost, and the higher you can improve your quality outcomes by ensuring that you have control of each component of that healthcare delivery system. This is where we're seeing a lot of the focus in consolidation today, the scale and the scope and the coordinated structure. Those two things together, if merged correctly, can ideally result in high-performing operations for the payer or provider that's engaging in the consolidation activity. One of the key challenges, and something that I would ensure that a community like Santa Barbara keeps in mind, is that as you see this rapid consolidation, one of the risks is that you lose those truly local provider organizations. Those providers like VNA Home Care or VNA Hospice Care that really know your community, who have been here for so long, who understand the populations, the patients, and may know generations of families and have provided care for various generations of those families. We have to ensure that we maintain that local connection. It's not going to stop consolidation, but it's something that we can't lose sight of as we see this occurring across the country. This was a really interesting statistic that I wanted to make sure folks understood as we talk about this consolidation, which is that as we see more and more expansion across scale and scope of services across the country, what we're seeing is a merging into new lines of business. One of the key examples I've placed here is really the expansion of providers into the payer market. And this was a study that was just released last week by Avalier Consulting, a DC-based think tank, basically, that basically said more and more providers are becoming payers. 60% of new Medicare Advantage plans in the last 2 years alone are provider-based. That means physicians are becoming payers. And that gets directly to this concept of expansion at scale and scope to ensure high-performing operations. These are some of the requirements for success in each one of these areas. Increasing your scale means that you have the enhanced ability to compete in the marketplace. If you're the payer and the provider, you actually have a better control on how you're serving those patients. You have a greater number of the patients, and you can better control how they are stratified across your population. You also, importantly, have the financial strength to participate in risk-based models. This is a contracting model that the folks on Bob's team in the contracting office are well aware of. One of the key components of the value-based healthcare economy is really how are we challenging our providers and our payers to improve their healthcare outcomes. And one of the ways that we're doing that is placing them at risk. Placing a provider or a payer at risk basically means that they're not going to be paid unless they hit a certain outcomes benchmark. So for many, that example would be, what is your readmission rate for patients who have congestive heart failure? That readmission rate has to be under a certain percentage on a monthly basis in order to ensure that that payer or that provider actually is paid at the top of the scale. Placing a provider at risk is the quickest way to ensure that outcomes are improved and achieved and targets are hit. But this is becoming the norm for all providers across the country, whether it is a physician group or a home health or a hospice organization. So this is going to be very important, having that financial strength in order to ensure success in risk-based contracting. It's also going to help drive innovation. Organizations need capital to innovate. They need capital to develop new programs. They need capital to expand into new markets. And that consolidation and strengthening gives them a greater opportunity to innovate and provide new services to new populations in their communities. And then finally, the new role, which is really where we see great success for organizations who are becoming change agents in their communities. It may be as simple as an organization stepping outside their normal provider box. For example, VNA Home Care expanding their palliative care program, or VNA Home Care becoming more and more of a wellness and health promotion organization. These are opportunities for traditional provider organizations to provide innovative programs to help support populations in need in their communities. This is just a quick example of some of the merger and acquisition and partnership activities. And as I was talking with Lynda and Keith this morning, we were talking about some of the different partnership models that we see across the country. And it's everything from home care organizations entering into partnerships with physician groups to ACOs, accountable care organizations, flat out acquiring VNAs and other home care organizations. One of the best examples we have is the VNA of Boston, having been acquired by one of the first pioneer accountable care organizations in the country. This was an example of an ACO that really just didn't get the value of home-based care. And yet the CEO of that organization for several months kept going back to the CEO of the ACO and literally beating on his door and saying, "You need me. Here's what I can do for you. Let me help you with these various patient populations." The CEO finally gave the VNA a very small population to manage, and within 2 months had more than tripled the size of the population, and within 6 months had just bought the VNA. This is a great example of the type of partnership that results from a demonstration of value, of quality partnership, and of a great opportunity for organizations to increase scale and improve outcomes. The next trend is really quality, and I attribute this quote, "Quality is the chariot to payment," to one of my board members at the Visiting Nurse Association of America. This is a woman who worked at a national accrediting organization for many years as a CEO, and who is a quality guru, and I'm fortunate to have the opportunity to work for her. And at our most recent board meeting, she said, "I don't want to talk about anything but quality. Quality is the chariot to payment." I'm scribbling that down as fast as I can because I thought it was a fantastic quote. But this is really a critical opportunity for all provider organizations. And I know that Lauren with the health plan is in charge of the quality office, but she will understand, and many of you in the room will understand, that there are so many opportunities and so many measure sets that are attempting to demonstrate a provider organization's quality, whether it's for payment purposes or for population health management purposes or both. This is really where you're going to make your mark as a provider organization. The problem right now is that there are any number of quality measure sets, whether you're at the federal level or at the state level or at the provider level or at the very local community level. What matters to the community is going to be what's measured, and what's measured is going to be how you get paid. And so we've referred to this as the Tower of Babel of multiple quality measurement systems. This has really been a problem over the past couple of years since the passage of the Affordable Care Act, but what we're starting to see just in the last couple of years is a consolidation across these measure sets. And I've put two examples here. One is the IMPACT Act. I don't remember what IMPACT actually stands for, but the purpose of the IMPACT Act is to take all of the post-acute care segments, home health, rehab hospitals, long-term care hospitals, and skilled nursing facilities, and develop cross-cutting quality measures for all four. That way, we can fully understand once and for all where a patient should be discharged to after, for example, a knee replacement. Based on that patient's particular situation and care needs, should they go to a skilled nursing facility or should they go home for home care? Or should they just be discharged back into the community without any post-acute care at all? The IMPACT Act attempts to understand where is the best setting for, first, a population, and second, an individual payment or an individual patient. Finally, payment will be tied to these outcomes measures for the providers who are serving these various post-acute care segments. So this will be the first opportunity for an apples-to-apples comparison across those post-acute care segments. The second is just a very recent announcement. AHIP is America's Health Insurance Plans. It is a trade association in Washington that represents the vast majority of the managed care plans in this country. AHIP and CMS partnered with a lot of different provider groups for the first time to develop key measures that are cross-cutting providers and physician groups. They've got about 8 different measure sets. It's the first group of measures. They are working to develop more, but this is a really critical development in this evolution of cross-cutting quality measures, something to watch as an example going forward where we will see additional integrated quality measure sets coming down the road. The key to all of this is that value trumps volume. Previously, Medicare paid on a fee-for-service basis. Fee-for-service means you go to the doctor sees you, the doctor does something to you, you leave, the doctor gets paid. Value-based payment means you are sick, but the doctor knew you were going to be sick, or anticipated that you were going to be sick, or anticipated that you were going to go into the hospital, provided a care manager to try and improve your condition before you went to the hospital to keep you out of the hospital in the first place. If a hospitalization was avoidable, they kept you out of the hospital. If it wasn't, they planned your hospitalization, and then before you even left the hospital, they had a plan for your post-acute care or your recovery to make sure that you didn't have to come back to the hospital. All the while carefully monitoring to ensure that you received the right care at the right time and the right application of the right amount of care. That's the difference between volume and value. This is what we're going to see replicated in communities across the country. What we're seeing with the proliferation of accountable care organizations across the country is this accelerated adoption of these types of value-based healthcare delivery and payment models. The key components that I have here, implementing cost-reducing products and technologies, whether it's a remote patient monitoring technology that can monitor someone at home to ensure they're taking their medications as required, or it's an electronic medical record that might connect the home health agency with the primary physician group that's treating a patient. To optimize limited fee-for-service resources. One of the key components of the transition to a value-based healthcare delivery economy is a significant reduction in the amount of dollars available to pay all the providers in the system. So we're doing more, better, with less. And that's just a fact of life because we have so many more people in our healthcare delivery system and yet not much more resources in terms of financial resources to help provide for their care. At the same time, we need that capital to innovate and invest in the healthcare value-based economy. And so these are really the fundamental factors driving this proliferation of value-based payment models and provider models. As I mentioned earlier, it's the right care at the right place at the right time. And then finally, this is an important component for the care manager on Bob's team. How do you manage all of the care managers? If you have a physician group that has care managers that are trying to make sure that Mrs. Smith is taking her medication and that she's getting her rehab therapy, if you have a post-acute care manager who's trying to coordinate post-acute care for Mrs. Smith who may have congestive heart failure or who may have had a mild stroke and is now back in her home in the community or even a joint replacement, you have to make sure that all of the care managers assigned to the various conditions for which Mrs. Smith is being treated are talking to each other. This is a growing concern as everyone has a care manager who's trying to mitigate cost but also improve health outcomes. This is just a quick representation of the shift that we see in the amount of financial resources in healthcare delivery. So over the next 10 years, well, from 2013 to 2022, we were going to see $260 billion cut from hospital payments across this country, primarily from Medicare. And that program, of course, serves the over 65 and the under 65 disabled population. We're going to see $415 billion cut from the fee-for-service, the traditional Medicare program. And we're going to see CMS rapidly, CMS is the Center for Medicare and Medicaid Services. They are the organization that runs the Medicare program. We're going to see them shoving every provider they possibly can into a value-based payment model. And this is really what that goal for the movement to value-based, or as CMS calls it, alternative payment model, alternative being anything that's not fee-for-service or volume-based payment. So you'll see that for 2016, the Medicare goal was to have 30% of their payments linked to quality, or participating in alternative payment models. CMS announced on Friday of last week that they hit that 30% goal by the end of 2015, so a full year early. So now they are continuing to push folks toward their 2018 goal, where they want to have 50% of their payments in an alternative payment model, but at least 90% of the payments linked to at least one quality measure. This is how quickly the biggest payer in the country, Medicare, is driving this change to a value-based economy, and it is going to impact all other payers. What Medicare does at the federal level for the federal population of Medicare beneficiaries funnels down to states and funnels down to private payers as well. So we'll continue to see this moving forward. This is a very busy slide, I apologize, with some of the most important capabilities for success in a value-based healthcare delivery environment. And we've talked about some of these already. What is the technology component that you need? This relates to your data needs and requirements, your performance management. How are you tracking your performance? What are the quality measures that you are working toward or being held against? Care delivery transformation is really that population health focus. Every organization needs to be looking at how they are changing care delivery in their organization and for the populations that they serve. Change management really talks about that pay for value and having your leadership think innovatively about how they offer services in the populations that you're serving. And then finally, stakeholder engagement. And by stakeholders, we mean both your partners in the healthcare delivery, but also your families and caregivers in your community and the populations that you're serving. So I'm going to shift from some of those broader trends and talk for a few minutes about some of the policy initiatives that are really driving this. And I've touched on a couple of those, but I want to specifically talk about some of the programs now that are underway. These are some of the most important and I think programs that folks are most aware of that are driving value-based shifts across this country. The shared savings bundle payments, MA is Medicare Advantage payment reforms, and then some of the other more provider-focused models down here. These are all programs that were authorized and implemented under the Affordable Care Act. Now, you might not have all of these in the community of Santa Barbara, but I can guarantee you that they are impacting the way care is provided and paid for here on some level. For example, the Shared Savings Program only engages approximately 75 accountable care organizations across the country. But what we see in the more than 700 accountable care organizations that exist across this country is a replication of those payment models and those quality measures. And so even if it's not a specific Medicare-sponsored component, it is being replicated in the private sector as well, because that's where they see innovation and that's where they see the industry moving as well. So I think this is a really important statistic as well. The number of individuals covered by federal and state programs has increased by nearly 1/3 since the passage of the ACA. That figure became outdated on Saturday when CMS, the Centers for Medicare and Medicaid Services, put out a report indicating that since the passage of the Affordable Care Act, an additional 20 million beneficiaries across the country have obtained health care coverage. And they're getting this coverage through primarily the expansion of Medicaid here in California and in other states across the country that have made the decision to expand their Medicaid populations. And that's been a critical driver of healthcare coverage and access. And in each one of those expansion populations, you have these quality-based programs, these value-based programs that are really driving the engagement to keep costs down for these new populations, but also to ensure that they're getting the right care at the right time for the right cost. So one of the other trends is really care redesign, and this gets to the population health management model that we were talking about earlier. Care redesign involves thinking about how you're providing care. One example is in the home health world. A lot of our members provide a certain number of visits depending on the reason for hospitalization of a patient. So, for example, let's say that Mrs. Smith had a knee replacement and she's discharged back into her community and she has been referred to a VNA, a visiting nurse agency, providing home care. Many of the VNAs just automatically provide a certain number of visits, let's say 9. They've always done it that way. But care redesign requires them to understand how many visits Mrs. Smith actually needs in order to ensure that she's recovering, in order to ensure that she's not going back to the hospital, in order to ensure that her knee replacement experience is successful. And so this care redesign really involves agencies at every level and providers at every level understanding, are they providing too much care? Can they provide fewer visits and achieve the same quality outcomes? It's not just doing things the same way because that's the way you've always done them. The other components here are quality and performance measurement and data sharing that supports all of those activities. And that's really how you understand how much care Mrs. Smith needs. What does the data indicate that her condition is going to require? And then, of course, there's the gain and risk sharing, and that gets to how many visits? How much is it going to cost you to provide that care for Mrs. Smith when she has the joint replacement to prevent her from going back into the hospital? Because once you have that rehospitalization for Mrs. Smith post-joint replacement, you as an organization are going to lose money, whether you are the payer or the home care organization who is providing that care. It's really critical that we begin to look at these care redesigns with a focus on outcomes and a focus on health in order to ensure that we can provide exactly what Mrs. Smith needs, but doing it at the lowest possible cost, reflecting back to all the money that's being taken out of the healthcare delivery system. One of the key areas where we see great innovation is really at the state level. The Affordable Care Act provided significant incentives and opportunities for states not only to expand their Medicaid programs to cover more populations, but also to give them considerable flexibility in how they do that. And I'm going to give you a couple of examples in just a minute about the different types of approaches that states have taken. But these waivers are all provided through the Centers for Medicare and Medicaid Services under the authority of the Affordable Care Act. And they really are allowing states to emerge as some of the most innovative providers and payers across the country in providing additional care for Medicaid-based populations. And so we see on the right side of the slide here some of the ACA, the Affordable Care Act, initiatives under Medicaid expansion that are allowing states to provide different types of care for different populations. A lot of these populations are low income, they have special behavioral health or long-term care needs, and it is a really challenging population in many cases for organizations and states to not only contact, but to assess and to engage and manage in a long-term way to ensure that there is a constant opportunity to help improve their care and their outcomes. And so the ACA did give states a variety of opportunities and flexibility to better engage those populations. So obviously, we're here in California. You all are intimately aware of some of the reforms that are underway here in California through your waiver program under the Affordable Care Act. I'm not going to spend a lot of time on this because you all know what's going on in California. But I do want to compare for you a couple of the other states that I have here. Basically, what you have in California is a hospital-based reform. You've got a whole person pilot that really looks at all of the needs of an individual in their healthcare needs. And then you also have a global payment pilot. And the global payment pilot is really that opportunity to provide a bucket of money to provide all of the care that an individual needs. And that's a really critical testing ground that we're seeing replicated in many states across the country. And then finally, that final bullet is really that long-term support and services opportunity to support not only dual eligible populations, those both Medicaid and Medicare populations, but other populations in the Medicaid program as well. So let me talk about the difference in two other states. Colorado is another state that's really leading the way in innovating their care delivery models. Now, as opposed to taking the hospital or the provider group approach that California has taken, Colorado has taken a regional approach. Colorado has developed 7 regions across their state, and within each one of those regions, they have one provider group that's responsible for the care and payment for all of the beneficiaries within that population. Now, there are many physician groups within those providers, those regional provider groups, but this is the approach that they've taken. It's working out extremely well for Colorado. In the first 3 years of existence, this approach in Colorado has resulted in almost $40 million in savings to the state. So this is a model that's being held up for other states to look at in terms of this regional approach. Now, I understand Colorado is not California. They don't have some of the population challenges that you have in this state, and they certainly aren't as large. But it is one area of the Medicaid waiver reform where we're seeing some significant success. Another is New York, and I know that we tend to look, bi-coastal at New York and California and what they're doing, and I frequently speak with the folks in New York about what we call their DSRIP waiver. This is their Medicaid waiver under the Affordable Care Act, and it really provides a significant degree of coordination among the various physician networks. The important thing here is that there's a specific percentage goal that these care networks have been held to. They are required to reduce by 25% preventable hospitalizations with their population health targets. And that's really, I think, a significant percentage reduction goal that they've been given, and some of the areas are really challenged and struggling with this. Finally, they're integrating their LTSS programs, and this is a really critical goal for New York and the populations that they see. This is one of the most challenging areas of the New York waiver program. There's a lot going on here. The implementation is not complete yet. It is a struggle for many of the providers in New York. They aren't seeing the results yet that Colorado is seeing, but they are very far down the path towards implementation, and they do see success in the future. They just have a couple more years, I think, to get it fully toward this 25% hospitalization reduction goal. So I want to end on this final trend, because this is really underscoring everything. Consumers are the center of the healthcare delivery system. We cannot meet these quality goals. We cannot achieve the cost reductions. We cannot prevent the rehospitalizations or the primary hospitalizations without engaging consumers and understanding their goals and helping them understand the opportunities that they have in their communities to access care. This is a result of the price transparency measures that we see across the country, helping consumers understand the true cost of healthcare, helping them understand how to shop for healthcare, where they can do so for certain conditions and procedures, and really helping to engage them in a variety of ways, whether it's online communities or providing them with alternate settings for care like Minute Clinic. These are some of the most important ways that we see consumers being engaged to better manage their care. This is just a basic statistic that shows as we move to these new value-based care delivery models, value-based care economies, more and more consumers are going to be in control of the healthcare dollars. as we see by 2020 an estimate that 50 million individuals will have health savings accounts. That's individuals, those are families as well. So I would multiply that by 2, really, if you think about all the kids and spouses that are going to be in there. These are the folks who are going to be controlling the healthcare dollar, making the decision about where they're going to go for their care and who they're going to pay for their care. They're going to want to know who's the highest quality provider. They're going to want to know who's the best provider for a certain condition. And all of those Tower of Babel quality measures that we're seeing are going to be important to help drive consumers to your provider organization, or to enroll in your payer organization, your health plan, or to choose your hospice. These are the folks who are going to be making those decisions, and we've got to give them the information and be transparent to help them understand how to obtain the best care and the best outcomes for themselves. And so I'll end with this: the consumer being supported by all of the various services that you in the room represent, and helping them understand who has the highest quality, who has the best value, who is really innovating across their community to provide the type of care that they need. These are just a few of the things that are driving healthcare delivery reform and value-based economy reforms across our country. I hope that this is a great segue into the panel discussion that will follow, where you're going to be talking more specifically about the role of healthcare providers in your community, your beautiful community here in Santa Barbara. I'm really honored to have been invited, and thank you so much.